So thank you, everybody, for being here. Thank you for the beautiful introduction. I'm incredibly honored to be here. This is not something that I would have ever guessed was going to be part of the trajectory of my life, and the idea that I'm able to take the stage with these fine people here is truly an honor that I can't even begin to express in a meaningful way, I don't think. So our guests for the first panel on evidence-based decision making. I'm just gonna go because I can't see the the thing over here, but we've got Dr. Monica Gandhi, Dr. Charlotte Haug, Dr. Marty Makary. He's got a recent book out, by the way, on blind spots, which is very fitting for what we're doing here today. Amazing. Dr. Andrew Noymer, Dr. Doug Owens, Dr. Josh Salomon, and Dr. Anders Tegnell. So thank you very much, all of you, for being here. I look forward to a very spirited debate or spirited discussion. And I just, to piggyback off what was said earlier, this is just one small step in a long journey for healing for our country and for the population of this world. And it is so important for everybody that is here participating, thank you, and for everybody here that's listening, thank you. The conversation is where it starts. The conversation has to happen for the healing to begin, and we will get there. We will get there. So, the UK COVID inquiry has highlighted misinformation spread by a wide variety of health professionals. It also showed how early transmission of SARS-CoV-2 could reasonably be known and acted upon by public agencies and healthcare facilities. What lessons from the UK COVID inquiry are most important to apply today in the U.S.? So that will be our first question, and we will start with Dr. Gandhi.
So I think my perspective was that during the pandemic, is I was coming from an HIV doctor perspective, because I'm an infectious disease doctor, but do a lot of HIV. And so I looked back at the beginning of the HIV pandemic, which I think is a pandemic, and is nowhere near over 40 million people living with HIV as of the latest count. And at the beginning of that, there was a very compassionate response from the public health community. There was a question of meeting people where they were, figuring out what they needed. And I'm not talking about the political community, I'm talking about infectious disease doctors, public health community, that the idea was that if we couldn't keep people away from each other just because there's an infectious pathogen that in this case was spread sexually, but that you use a harm reduction model and figure out what people needed, and then within that concept of what was needed, keep them safe. So I think what happened at the beginning of HIV is that the president at the time was conservative, 1980, and so the public health community, which is usually leans left, was very opposed to just say no and sort of principles that were very harsh and didn't in any way take into account human needs. And the public health community, I think, developed a very compassionate response to HIV that they're still trying to work on today. I think what happened with COVID is that also the president at the time in the United States was conservative, so the public health community went oppositional, but the problem was that was really political in the sense that things like school openings, things like people's needs were not taken into account because everything was sort of in reaction as opposed to a very clear scientific response. So I did write a book on COVID called Endemic, a post-pandemic playbook, which no one's read, but that's okay. And it's at Mayo Clinic Press. And it's very evidence-based in the sense that everything that I write about with virology, immunology, T cells, school closures, which is chapter 5, and a post-pandemic response, which is the last chapter, kind of step by step what to do next. has a lot of references to each statement. So I think we needed to have used, because this is an evidence-based panel, needed to use more evidence in our decision-making and less politics or reaction or response, but just if you just followed the evidence, we likely would have had a more tempered and less political and less angry response like the Norwegian countries, Scandinavian countries did, which was they are now left with more trust in public health. There was a poll recently that Norwegian people actually have great trust in their public health officials. And our latest poll, which was published in JAMA Network Open just a month ago, shows that we have about, in this country, 30% trust in public health. So we really we must have done something wrong.
Yes, definitely. Dr. Haug, 5 minutes.
Yeah, so since you mentioned the Nordic countries, I'm from Norway, Anders Tegnell from Sweden. Very similar countries, very different responses to COVID. And I would say, at the end of the day, our results, I mean, the all-cause mortality since 2020 is pretty similar. So that also tells you something. But since you started talking about HIV/AIDS and the difference, I was also doing HIV/AIDS research in the 80s, 90s. It's also a question of pace. So with HIV/AIDS, it took a very long time until we knew things about the virus. Till we knew things about how we responded, how we could treat it, that it was a virus, actually. But here, it was a complete difference. It was a rapidly spreading virus. We knew, actually, very rapidly what it did to us, the sequence of it, how it affected people, how it infected people. But it also meant that information changed very rapidly. And so that was also confusing. But I would argue that we really need to be prepared for that type of rapidly changing information for a new pandemic. Because that will happen next time too. It's not only about evidence, it's also about being prepared to change your opinion as pandemic develops. And especially with an RNA virus like this coronavirus, it will mutate, it will be different. Yeah. So I think we have been mentioned, Laura Carstensen talked about the psychology of decisions under uncertainty, but we have to, and there will always be uncertainty, but there will also be rapidly changing information, and we will have to be prepared to change our opinion rapidly.
Yes. Yes. All right, thank you, Dr. Haug. Dr. Makary.
Thanks. Well, during COVID, I went back to visit my family in Egypt, and I had a bunch of colleagues and friends at the hospital ask me, is it safe to go to Egypt right now? And I love these folks. They're very smart, MD, PhDs, no offense, Jay, triple boarded in a medical specialty, and everybody was so concerned about my safety in Egypt. I told them, we live in Baltimore. And it just struck me how smart people can all believe the same thing and have these blind spots. And during COVID, I almost saw this herd mentality take over. And it's okay for us to all have the same theory about transport mechanism within a cell, and that's common. You have sort of prevailing thoughts. But the way that any dissenting opinion was silenced, crushed, sidelined, railroaded, that was remarkable to me. But I had a good experience at Johns Hopkins personally. My dean invited me a couple years into the pandemic to speak to all of the department leaders. He said, you know, Marty, I know you have a different perspective on the vaccine mandate for young, healthy people who already recovered from COVID. I know you have a different perspective on cloth masks on toddlers. I know you have a different perspective on hospital visitation policies. I was very vocal that not allowing people to visit their dying loved ones was a human rights violation. And so he said, why don't you come in and speak to all of the department leaders? I'd like for them to hear your perspective. And I had this incredible opportunity to speak, and people politely listened. And then a couple years later, the data had sort of caught up with all these issues, and now we had the opportunity to evaluate COVID policy. And so I suggested a follow-up discussion. And there was not a lot of interest. It was sort of like, well, you know, it's kind of over. We did our best. And I thought, here is the largest public health intervention in modern history. And there's no interest in evaluating it with good scientific methodology. And that blew me away. And I thought, if we got this wrong, if we got so many issues during COVID wrong, prolonged school closures, go down the list, what else are we getting wrong in medicine today? Where else is the bandwagon thinking harming our ability to discover things or to promote a healthy conversation? Well, it turns out COVID really is not a one-off. We have seen the hubris of the medical establishment create modern health crises that we are still dealing with and treating today in modern medicine. The dogma that opioids were not addictive for 30 years ignited the opioid epidemic. There were a lot of smart doctors saying, no, they are addictive, but they were sidelined. The dogma that hormone replacement therapy causes breast cancer, when the data never supported that in the WHI study, has resulted in unnecessary suffering of over 50 million women since that announcement 22 years ago. The dogma that young children should avoid peanut butter until they turn 3 from the American Academy of Pediatrics, and echoed by the National Institute of Allergy and Infectious Diseases, for 15 years ignited the modern-day peanut allergy epidemic. The dogma that the food pyramid was the top recommendation. That was the number one thing we told patients in our offices. They came in to see us, eat better, here's how we define eat better, avoid fat. Where did that come from? Dogma. Turns out there were smart doctors saying otherwise. And today, what are we getting wrong? In my opinion, today's giant blind spot is that the bandwagon thinking has ignored our poison food supply. Why are we seeing all of these chronic diseases surge right in front of our eyes? Obesity, prediabetes, steatohepatosis now affects 1 in 4 children. You'd rarely see it just a generation ago. All of these chronic diseases are rising right in front of us, and what are we doing as a medical establishment? We are so busy billing and coding and medicating and operating, we cannot see the forest from the trees. We cannot see that we have poisoned our food supply, added highly addictive engineered chemicals, removed our food supply. As a medical profession, we move the food supply to get rid of natural fat and replace it with ultra-processed foods and refined carbohydrates. And we've added pesticides that all have altered the microbiomes of a generation. So if we don't have civil discourse, we're not going to discover the cures for certain cancers. Right. We're not going to move forward.
That's absolutely right. Thank you. Dr. Noymer.
Thank you. I'm Andrew Noymer from the Wen School of Population and Public Health at UC Irvine. First of all, I'd like to thank Jay for organizing this conference. I'd like to thank my fellow panelists and all of you in the audience for coming this morning. Jay said we would all have 5 minutes to make some introductory remarks, so I have 5 bullet points. So the first is a quote from Moshe Dayan, who said, if you want peace, you don't talk to your friends, you talk to your enemies. Well, I don't consider anyone with whom I have a difference of opinion about COVID to be my enemy, but I do have differences of opinion with a large number of people in this room. And it's in the spirit of talking to people with differences of opinion that I agreed to come here this morning, and President Levin alluded to in his opening remarks about people who are reluctant to join us. But academic freedom is one of the core values at the University of California, where I teach, and I think it's important for us to have these conversations. Specifically about why I have differences of opinion with many of you, I believe a large number, certainly not all, but a large number of interventions that were done during the COVID pandemic were justified, and indeed, I think, were evidence-based. So I look forward to having that conversation on this panel and all day today. I'd like to make it clear, however, that I'm not a mouthpiece for the Centers for Disease Control or for any other government agency. There's plenty of goody two-shoes epidemiologists out there who just say whatever the CDC is saying at the time. I'm not one of them. I can give you 2 specific examples. In July 2021, when the CDC was insisting that breakthrough infections were a very rare and uncommon occurrence, despite the fact that their own data published in the MMWR made it clear that breakthrough infections were happening and were going to be a humongous problem. I was quoted in the Washington Post criticizing Walensky in the strongest terms about the CDC's conclusions at the time. And I believe their current advice about the length of the isolation period during and following a COVID infection is extremely unwise. Fourth, I'd like to challenge us all to think about the COVID pandemic and the government response to the COVID pandemic through the following lens. And this is a little bit specific to the United States of America, but I feel like many other countries followed the United States' lead. Whether or not that continues to be true in the future remains to be seen. But I'd like us to consider that there was this, Tony Fauci is probably one of the most influential people in the American government response to the COVID pandemic. And there was, at first, a very severe response, and I'm sure we're going to have plenty of time to talk about this today, because the desire was to contain COVID, get the upper hand on this virus. After a certain point in time, the CDC and the US government response pivoted to everything's back open, you don't need to mask, you don't need to isolate after infection, and so on. And these aforementioned epidemiologists who just parrot whatever the CDC says, turned on a dime and said, oh yeah, everything's back open. I believe that the origins of the SARS-CoV-2 virus are that it's a gain-of-function escape. It's an experimental virus that escaped from a lab, and Tony Fauci is intimately linked to the funding for the experiments that created this virus. He desperately wanted to keep a lid on this so that it wouldn't be a big deal. And when it became clear that the genie was out of the bottle, the pivot occurred to say, COVID's no big deal. It's nothing. It's nothing, it's a cold. Disregard these 20 million deaths. We can just move on.
30 more seconds.
So I think that's important to consider. And lastly, building on the lab leak hypothesis, my PhD advisor, David Friedman, one of his last words before he died was, keep after the rascals. And for those who staunchly defend COVID as being a zoonotic disease, I would just like to say that we will never stop pursuing the truth until we know where COVID comes from.
Thank you, Dr. Noymer. Thank you. Dr. Owens.
Thank you very much. I'm Doug Owens. I'm a professor of health policy here and a senior fellow at the Freeman Spogli Institute. I'd like to just start by thanking Jay again. He devoted a lot of his life to this. And if you'll indulge me, I want to take a chance to thank our unbelievable staff who've also spent much of the last part of their life working on organizing this. So please join me in that. Welcome, everyone. It's a pleasure to have you here. I just want to first take, people have mentioned it, to remind us why this is so important. So over 1 million deaths in the U.S., millions of people living with long COVID, which varies from mild to absolutely devastating. We have very, very little to offer them. We don't know what to do for them. It's under-researched. And so the toll in terms of morbidity and mortality has just been staggering, as Jay pointed out right at the beginning. And that's why what we're doing is so very important. I will also, as we think about health policy and public policy decisions, I also though want us to remember that there was a great deal of heroism in the clinical providers who were working night and day around the clock to provide care under the direst circumstances, often at risk to themselves. I'm a primary care physician. I was doing primary care during the pandemic, and in my clinic, the residents were volunteering to go and be on the COVID wards or go to the ICU to take care of people at a time when there were no vaccines and there was really unclear how much the risks were. These people did a lot of tremendously heroic things, and I hope we would just keep that in mind and remember that. Pivoting a bit to public health, obviously I feel we owe our public health colleagues a great deal of thanks for trying to keep us out of harm's way. And that's what I wanted to make a couple of comments about. And I want to talk really about, I want to make one point, and that is in this epidemic, timing was critically important in terms of intervention. So if you think about epidemic growth, and I spent much of my career doing mathematical modeling of infectious diseases, you start with a very low number of cases, and then, at least in some pandemics and some diseases, it explodes exponentially, and that's what happened in COVID. So when we think about the rapidity of growth of an epidemic, one of the things we talk about is the doubling time, which is just what it's how long does it take for the cases to double? And so in March of 2020, when there was a shelter in place here, now people looking back think that at that time in New York City, the doubling time of the epidemic was about 2 days. So imagine what that means. It's so hard to wrap your head around it. If you have 1 million cases on Monday, you have 2 million on Wednesday, and 4 million on Friday. Your epidemic's grown by a factor of 4 in 5 days. So what that means is that the timing of interventions and the speed at which you have to make these decisions is just absolutely breathtaking. So if you're going up this epidemic curve, if you institute an intervention early, you have more people that you can help and protect. But maybe even just a few days later, many people have already become infected. So that timing bit is very crucial, and in the sense that the harms of, let's say, shelter in place, those probably aren't so sensitive to the timing. So if you go late, you might have given up some of the benefit that you could have obtained, and then the balance of benefits and harm changes. So this incredibly difficult decision making, because at the time, public health folks had very little information to do this. And remember that as somebody is infected today, it would take a week, maybe more like 2 weeks, for them to be counted as a case. And so there's this lag. You don't see what's going on in terms of the number of cases are occurring, but at the same time, your epidemic might be doubling every couple of days. So if you wait until you're sure and you actually see the cases, then you may well be much too late. So just one element of the challenges in these decisions that public health folks had to make is it's just in this pandemic, things had to go so incredibly quickly. And with very, very little information. And maybe we can talk more about that. Thanks very much.
Thank you so much, Dr. Owens. Thank you. Dr. Salomon.
Well, let me echo my fellow panelists in thanking the organizers, and thank you to our moderator, Mr. Wilkinson, and thanks to you all for joining. My name's Josh Salomon. I'm a professor of health policy, and my background is in decision science. So during the pandemic, a lot of the work that I did aimed to try to inform the public health response through data analysis and modeling. As a decision scientist, I focus a lot on how we think about decisions when information is imperfect, when the stakes are high, when there's a lot of uncertainty. My spouse will tell you that I am annoyingly always a decision scientist. Doug, by the way, is also a decision scientist, arguably less annoyingly so. But I wanted to share with you my thoughts from that perspective, and in particular, 4 points about decision-making in a public health emergency like COVID-19. First point is that good decisions and good outcomes are not the same thing. So we care about outcomes, of course, but a key tenet in decision science is that good decisions don't always lead to good outcomes. And physicians know this, of course, very well. During the pandemic, as you've heard from others, decisions had to be made very quickly based on limited information. But when some decisions resulted in worse outcomes than others, we should avoid the temptation to jump to the conclusion that the decisions themselves were flawed. Good decisions use good available information, they balance risks, they adapt as new evidence emerges. In real time, decisions are made with a ton of uncertainty, but outcomes are often judged afterwards with perfect vision hindsight. And so I will suggest to us all that rather than judging decisions based solely on outcomes, we should ask about those decisions. Were the objectives clear? Were the trade-offs acknowledged? Did the decisions reflect current evidence? So that's the first point. Second point is about managing uncertainty transparently, and some of the other panelists have already touched on this. Major challenge, as you all know, during the pandemic was in managing uncertainty while maintaining public trust, as Dr. Gandhi focused on. The public understandably wanted certainty, but decision makers often had to act with incomplete data. And so as a result, there was sometimes a tendency to overpromise or oversimplify. There were premature declarations of the pandemic's end. There were overconfident timelines for returning to normal. So greater transparency, I think, really would have helped. Decisions needed clearer explanations, and I think Andrew's comments spoke to this, of why they were made, the risks involved, and what remained uncertain. But I also really want to say this very clearly. Public health professionals during the pandemic faced extraordinary pressures. Many of them were harassed relentlessly. Some were driven from the profession entirely. I see some of my public health colleagues in the room. And we are all worse off for having lost the expertise and the experience of many dedicated public servants. Mm-hmm. Third point I want to make, the paradox of prevention is that success is measured often by the things that didn't happen. One of the biggest challenges in evaluating public health decisions is that the benefits are often invisible. We all see the harms. We see the economic disruptions, the school closures, the toll on mental health. But it's harder for us to recognize the lives that were saved, the hospital systems that were not overwhelmed, the short and long-term illnesses that were avoided. In decision science, we think a lot about counterfactuals, about the things that didn't happen but could have happened. And these invisible benefits are as much a part of the impact as the visible costs. Avoided harms are part of the success story, even if they're harder to see. That's the third point. Fourth, I want to talk about adaptability. I won't emphasize this because others already have, but I'll mention a few examples. When vaccines became available, they transformed the decision calculus. And let us make no mistakes, vaccines were introduced only after extensive, rigorous studies provided overwhelmingly clear evidence that they were both safe and effective.
Take about 30 more seconds.
Thank you. 3 more seconds, my goodness.
30.
Okay. I will speak quickly. It still seems like not that much time, but here we go. But the rollout also brought new complexities, and I won't dwell on that. Let me make a final summary, really kind of bringing these together, which is to say, what will it take to improve our response to future crises? First, I think we need clarity from leaders about the objectives they're balancing, whether it's saving lives, saving livelihoods, addressing mental health. Decision makers have to be upfront about those trade-offs. Second, honesty in the face of uncertainty. And public health, as others have said, needs to adapt as new data emerge. And third, finally, we must ensure public health systems have the resources and the capacity to respond effectively. We need to invest in better data systems. We need to invest in public health infrastructure to enable us to make timely decisions in future crises. So I think if we can carry these lessons forward, transparency, investing in evidence, investing in public health, we can be better prepared to face the next crisis. Thank you.
Excellent. Thank you, Dr. Salomon. And last but not least, Dr. Anders Tegnell. Thank you.
And also for me, a big thanks for bringing me here from far away and meeting a lot of the people I've only seen online before in person. That's amazing. I've also, of course, thought a lot about the interventions that we did or did not over time. And I'm not so certain about how much of a difference they really did make. I mean, we can discuss that further. When we look at the end result, it seems to me like the context was a lot more important than actually what we did. And where the pandemic happened, in what country, and what kind of resilience we had in the country made a lot of difference. And countries are a lot more different than we think many times. And we didn't really play in that very well. I think Norway, Sweden is one example. We look very similar. But when you start digging into it, there's a lot of differences that explain the difference we had, especially in the beginning of the pandemic. So then you can wonder, why did we all go down and did the same thing, all of us? Because it was probably not a very good choice to make. And probably I think that the example of China set made a lot of people think that here is the easy solution. We always want an easy solution, so for some reason, even to complex problems. And that's why I think a lot of countries follow suit for that. And I think there was also a feeling quite far into the pandemic that we can actually stop this. And it's not going to take very long, so we can sort of have very harsh measures because we only have to live with them for a very short time. That, of course, was never true. And I mean, I'm not an academic, I'm a civil servant, but very much data-driven. And I think we didn't really use the data that were available very well. I mean, we need more data, we need better data, but we also need to be able to use the data much better than we did. Because in Sweden, we could see early on that, okay, people are really infected in the workplace to a very great extent. So let's focus our efforts on trying to close down the workplaces as much as possible. And I think those kind of focused interventions is something we really need to take with us into the future. Because now we felt unsure, and then we closed down everything. Instead of trying to understand, okay, what do we need to close down to protect the most vulnerable people in our society and flatten the curve as much as possible. And we also found afterwards, which I think is quite interesting, that it proved to be much more difficult to stop an intervention than actually start it. Because to keep your confidence of your population, it was very difficult 1 week to say that this is deadly serious, you need to stay home and do nothing. And a couple of weeks later say, now everything is okay. So, and I think what we also found was that trust in our societies is incredibly important. And I mean, it's easy to say, and we live in a world where this is deteriorating, which I think is terrible because it's going to have so many effects, not only in public health, but all over the place. So I think this is a really good possibility in meetings like this to have these open kind of discussions and rebuild trust so that we can have that. And it's not only trust between academia and the population, it's just as much a trust between academia, civil servants, and the politicians, because I think that was, to a certain extent, that was missing. Mm-hmm. That's why in many places politicians sort of kept on running and taking over the whole thing. And also, we need to understand that the pandemic is not a communicable disease problem. It's not a health problem. It's a societal problem. So we really need to get all our societies involved in this. And that took much too long this time for the whole of society to realize it. This cannot be solved by our hospital system. We need all to get involved to make this solved. And that leads me to my final thing. how important equity has proven to be. Because in societies without equity, this is hidden much worse. And even in society with a reasonable level of equity like Sweden, we could really see that this was hurting people with a low socioeconomic status and so much more than the rest of the population. So we need to be able to protect them much better and get that equity into place before the next pandemic is coming. Thank you.
Thank you, Dr. Tegnell. So I think what's so beautiful here is we've got 7 different professionals that have had very different experiences when it comes to the pandemic response, how they viewed the pandemic response, what they were doing, and just the idea that we can sit here and like I said earlier, a step to rebuilding trust. Like Dr. Tegnell just mentioned, trust is something that's sorely lacking. And if we do not figure out a way to rebuild that trust between the people and the public health establishment, we are going to be in a worse position going into the next one than we were going into this one. What part does academia play in rebuilding that trust? I would argue it's a big part. And having a diverse range of opinions, whether it be people that worked, on the AIDS epidemic back in the day, or AIDS pandemic, or looking at the blind spots in our current health system, and what we can do, what we can learn from those blind spots. But learning from those blind spots requires us to really do a lot of introspection. How do we learn from what we've made mistakes? I always say every mistake is an opportunity for learning, and I think it's important to have the humility to point out the mistakes that are being made. Just having these different personalities are absolutely awesome. So what I want to do, and I want to remind the audience, that QR code on the table, you can go and submit questions that will be reviewed and passed along to me up here. I do have to apologize. I forgot my glasses back at the room, so I'm going to do my best to read these, and if I can't, I'll ad-lib, and we'll hope for the best. So I'm going to start by asking asking our panelists, and this is such an important question. What is a policy that you thought was best during what was the policy that you thought was the best during the pandemic? But now you, looking back, think it was a misguided policy. So I would just like to, give a couple, just a quick answer from each of our panelists here. What was a policy that you thought was good during the pandemic, but now looking back was possibly misguided? Dr. Gandhi.
Well, I actually wrote a piece on vaccine mandates at the beginning of the vaccine availability in January of 2021 because I thought that vaccine mandates, especially in schools, have always helped curb infectious diseases. So I thought that was a good idea. And then just like the WHO, I changed my position on that when we figured out something that we always knew, that T cells and B cells are being created by the vaccines, but the antibodies will come down and the antibodies don't work as well as the variants change, and so then they weren't preventing transmission. And the WHO pivoted really quickly from the vaccine mandate to saying that will decrease public trust. And I went along with the WHO, but the US and the CDC was still talking about vaccine mandates much longer than Europe.
Thank you. Thank you. Dr. Haug, do you have a thought on a policy?
Yeah, it's. I think in the very beginning, I, as many others, was thinking that even the very tough lockdowns that we had in Europe was maybe a good idea, but also because I was certain that it would last very short duration.
The duration of the pandemic itself?
No, but because we knew from the beginning that those kinds of policies will harm more than they will do good in the long run.
Okay.
And so that, of course, I was thinking that that would happen, that we would change quickly, that we would sort of get back to normal and think about our ordinary policies during pandemics, and we didn't.
Okay. All right, very good. Dr. Makary.
I can't think of anything. I mean, the entire COVID policy of 3 to 4 years felt like a horror movie I was forced to watch, and I couldn't close my eyes.
Everything was
Almost.
everything was misguided. There was nothing that you agreed with. Okay. Dr. Noymer, what?
Well, rather than a specific policy about which I've changed my mind, I'd like to just highlight a really lamentable own goal, but in terms of lack of clear communication early in the pandemic about, I remember all these press conferences from Washington, D.C. about, well, is COVID being spread, from person to person? I mean, for Christ's sake, of course it is. I mean, it's a respiratory disease pandemic. And relatedly, and probably more importantly, the question about aerosol transmission and is COVID airborne, and the WHO, saying, well, we don't know, because the WHO was, through incompetence or deliberately being hyper-technical about, well, an airborne virus means an aerosol transmission route, which is a certain diameter size of water particle, versus droplet, which is a larger diameter size of particle, which in practice makes no real difference. It's an arbitrary distinction between droplet and aerosol. But, the WHO, saying, well, we don't know that it's airborne because some technicality about the definition of aerosol, which was synonymous with airborne in their view. But what the average person, wants to know is, how do I catch COVID, and therefore how do I avoid catching COVID? And so the distinction between droplet and aerosol is not important for that question. And the WHO and other organizations insisting for so long that we don't know if it's airborne is just such an incredible error.
Yes, I agree. Dr. Owens, can you think of a policy that you agreed with during the pandemic, but possibly at this point now believe it was misguided?
Well, I would pose it a little bit differently in terms of the timing, that an intervention that might have been a good idea at one point in time then is not as good an intervention at a different point in time, right? And Anders spoke to this. And let me give you one example. So school closures, very early, there was tremendous uncertainty. It was unclear what was going. I think school closures were reasonable. But the problem was then that they lasted for a very long time.
Yes.
And it was understandable in some respects because people were scared. They didn't want, teachers were scared. I don't know about students. Some parents were scared. So it was hard. So there's a set of interventions that, my previous remarks about the speed that you have to do something. You have to start them very, very fast. But then you have to know when to stop them. And that's challenging as well. And part of the problem, I think, both there was a lot of uncertainty and fear and uncertainty that Josh talked about, and the data that we had to make those decisions was just really sorely lacking. So I would think of the interventions more in terms of what's the right timing for them, how fast do you have to start, and then how do you unwind it, is the way I think that maybe we can learn something.
Can I just ask, though, the data were very clear from Europe in the summer of 2020 that the schools could be open free and clear throughout Europe, but no journalists covered it. We didn't talk about it in our circles. So the data was there. It's just we chose, not to talk about it.
Yeah, I'm not an expert on that, of course, but I would just say that I think that at least speaking locally, those decisions are very dispersed. Like even within our county, we have a jillion school districts, and they can do what they want to do, and so it's very challenging once you've want to unwind it and get that data into people's hands.
And I do have a follow-up question that's going to kind of go along with this, what you're saying, Dr. Makary, and that plays into the point of how we, how certain viewpoints and the ways that things were dealt with very narrowly and didn't look at the downstream effects of certain things. So I want to get to that in just a minute. But before we do that, I want to kind of finish our roundtable here with that first question, and that, Dr. Salomon, can you think of a policy that was, by all rights, something that you thought was good at the time, but looking back was probably misguided?
Yeah, no, I appreciate the question. I mean, I think a lot about what I got wrong, and I can give you a list, but you asked for one, so I'll start at the beginning, which is early in the pandemic. I believed that contact tracing could really help us. In that first wave, could help us get our arms around that first wave. It's a mainstay of public health interventions for infectious disease. As it turned out, there was just too much transmission, not enough staff, not enough money, too much asymptomatic transmission. And the things that might have been helpful, like kind of digital app-based tracing, I think there's too much suspicion of those. Mm-hmm. In the end, it just didn't turn out to be an intervention that did very much good for us in trying to get our arms around that first wave. And I initially thought it would have been. So that's example one. If we come back, I've got more.
Okay. And Dr. Tegnell, I mean, you as somebody who was, making huge decisions based on the information that was coming in at the time for your country, what is something that you thought was a good idea at the time, but maybe was misguided looking back in retrospect?
I mean, of course, there's plenty of things, as you said, that if we had known more, we would have done differently. I think one of the things we did, we were very concerned about protecting the elderly. And as part of that, we said we banned visits to elderly homes. This was not very good. And we eventually found out also, and we changed our policy after half a year or so. But that was very destructive and did not help at all, I'm certain.
All right, very good. So I want to play off for Dr. Makary, Dr. Owens, and then we'll kind of run it around the table here, the imaginary table. The public health leaders, and this is something that I've talked with Dr. Francis Collins about at length. Public health leaders focused very narrowly on minimizing deaths from COVID, and often it came at the expense of other social values, other things that we that really make our society tick. Being able to visit people, whether it be in elderly homes or put our children in school as they normally would go to school or attend funerals and things like that. Should public health pay more attention to the other side of the scoreboard in future health crises? I mean, I'll start with you, Dr. Makary, and then we'll kind of go around.
Well, this is one of the few places in America where we're actually having an honest conversation about the outcomes of COVID. And you saw the politicalization on both extremes. Comparing states wasn't really a fair comparison because there were too many confounding variables based on the advancements in treatments over time, and they weren't concurrent waves in each state. But Michigan and Sweden had the exact same concurrent waves, maybe due to the climate, the exact same timing of their waves. They had radically different COVID policies. Michigan was one of the most restrictive in the United States. Ultimately, what did the data finally show? Nearly double the deaths in Michigan compared to Sweden. Now, what do you do with that? Just ignore it? No one talk about it? You saw one or two pieces written about that, but how do we not evaluate these interventions? And you had Dr. Fauci saying in July of 2020 that teachers should wear goggles and gloves in the classroom to reduce COVID transmission. Monica Gandhi was saying in the day one that, hey, the other two coronaviruses that cause severe illness in humans, SARS and MERS, they were airborne. Why would this suddenly buck the trend? But you saw no civil discourse. And then when Dr. Fauci decided, hey, should we recognize natural immunity? He brought in 4 of his like-minded friends and had them vote in a little straw poll, and 2 voted to recognize it in the COVID vaccine mandate requirement, 2 voted not to, and he says, well, I'm just going to not recognize it. That's how decisions were made, and we wonder why public trust in doctors and hospitals in the JAMA study went from 71 to 40%, a 31-point drop, because you cannot put something out there with absolutism as if it's science when you're just shooting from the hip.
That's right. That's right. Dr. Owens, I'd like you to respond to that.
Sure. Yeah. I mean, to the question of whether they should pay more attention to the other values, other sectors, and I would, at first, I'd be extremely reluctant to tell public health people what to do. I'm not one. But I think they would like to. But let me explain a little bit, and many of you may know this, about how these decisions are made. So it's very different across the U.S. in terms of in jurisdictions about who's making the public health decision. So California, it's very distributed. So the county makes the decisions. Mm-hmm. And the people that are making the health decisions aren't getting any information about economic things, et cetera. They don't have a way to factor that in. And I would surmise that many would love to have had that information. And there are other states where it's very centralized, and then perhaps you have maybe a governor making a decision, or et cetera, who does have a broader view and maybe getting different kinds of information. But part of the issue is that the public health people, their remit is to protect public health, but they don't have either the authority, the information, or whatever, to do other things that you might want to do, say, employment assistance, et cetera, if a public health measure is going to have other negative impacts. That's not in their decision-making capacity. So we have people have to make decisions on one part of the problem, and that leads to some of these issues.
Yeah. I think one of the people that I've had the opportunity to speak with, and Dr. Bhattacharya has as well at a Braver Angels event, is Dr. Matt Willis, the public health director from Marin County, north of here. I think it's north of here, isn't it?
Yes.
He had a very community-based approach to dealing with the pandemic. They did very well as far as things go in Marin County. I like that idea of getting that community input. That one-size-fits-all thing is I think where we run into big problems and things get awfully muddy. So let's go around and just if the rest of you could take a minute or so to kind of give your perspective on that. How do we give process to the other things, not just the public health or the health being the myopic focus?
Yeah, I mean, I think holistically we only focused on one thing and didn't focus more widely on the impacts on society. And again, going back to HIV, there was actually a bigger focus, at least for those living with HIV, about other needs. And I thought this was more myopic. The 10-point plan at the end of this book is really simple, actually, but it's kind of based on Dr. Henderson's way to the fact that he eradicated smallpox, which is just you get to biomedical advances as quickly as possible. So accelerate vaccinations. That's now going to happen in any pandemic. We're going to be able to get to a vaccine less than 9 months because we have the technology to do that. But once you have the vaccines, you want to ease restrictions quickly because that will give people trust that, hey, we get back to normal life if we have the vaccines. So I think that decreased trust when the CDC in July 2021 said that we wouldn't see breakthrough infections, but vaccines were really great in improving severe disease. I think third is education and harm reduction instead of coercive, being more education. This is why we're doing it, but I promise we'll change as we get new data. Fourth is open the outdoors, because any respiratory pathogen does better in the outdoors, but we closed beaches and parks here, which was difficult and to throw people inside. Schools are a special case. We always have to think about how important schools are. Open them as quickly as possible. Avoid lockdowns because those are really impactful on other holistic aspects of public health. And anything sometimes doesn't work, like washing hands or decontaminating, stop doing it because it will decrease trust. And then treatments, and I think antiviral treatments, we're going to go into a new era now of being able to make new antiviral treatments. And we're in the final stage, preparing for the next pandemic. That's what we're doing here. you really do have to increase trust in public health. We have to behave better because we can't go into the next pandemic with this degree of trust. Nothing will work.
That's right. That's right. Dr. Haug?
Yeah, I think, public health to me is holistic. It's not about one virus or one disease. And the traditional public health is that it's to take in all kinds of aspects. And surely, from the beginning, if you look back 1800s, it was living conditions, it was hygiene, it was, we didn't even know about the bacteria then. So to me, the most surprising thing was that it became so myopic. Yeah. Because it's public health isn't really that. And WHO, if you look at that as sort of the global public health, they all the time, even through the most, sometimes they took down some information on their website, but all the time it has been there that you should think about the wider effects. You should not stop everything else, and you should think about, the real values in life. That is public health.
Absolutely.
Yeah.
Dr. Noymer, what is your...
Well, let me take my time to respond to two things my fellow panelists said. One of the advantages, there are numerous disadvantages, but one of the advantages of having spent much of the pandemic on Twitter is that I'm on the record for saying a lot of things. All my old tweets are still up, and a lot of the things we did, this is responding to something you said, Monica, were dunderheaded even at the time. And I said in March or early April of 2020 that closing beaches is a dumb idea. And something that you said, Marty, about comparing Michigan and Sweden, and I don't remember when I said this, but it was early in 2020. I tweeted that comorbidities matter a lot, and we're about to find out that the United States is not as healthy as we think we are. And I think, comparing, and this is congruent with something you said in your opening remarks about diet, but comparing the United States and Sweden is full of pitfalls because the American population has a lot more comorbidities than Sweden, and that played out to dramatic effect during COVID.
Certainly did, yes. Dr. Salomon.
Yeah, I won't repeat what other panelists have said, but I want to make a couple of additional points. One is that I agree that there was largely a focus on preventing mortality, and that over time, that might have been at the exclusion of giving due weight to other considerations. I think there are always trade-offs in decisions. In the early part of the pandemic, in March 2020, it made sense to focus on mortality. I mean, we all saw the images of hospitals in Italy. We saw the stacks of body bags in New York City. So, yes. Of course, the other considerations are there, but they're at points, they are clearly overwhelmed. I think over time, this gets back to the question of adaptation, I think those trade-offs really need to be revisited more nimbly than they were, and the sort of other considerations recognized. Last thing I'll say quickly is that I think schools are a good example where another mistake we made was to pit these as sort of in opposition strictly. You worry about safety and health, or you worry about education.
Either or.
And the economy, and I think that was very much to our detriment. Schools are a good example. We all wanted our kids back in school, but we should have been saying open schools and make sure that the kids are safe, the teachers are safe, the kids don't get infected and infect their older relatives. And that would have meant investing in cleaning the air, investing in rigorous testing regimens and sensible policies to try to contain infections when they emerge. And so I think we really missed the opportunity to say, we care a lot about health and these other things. Let's try to tackle them together instead of putting them in opposition.
Yeah, no, absolutely. Yeah, the either or as opposed to and, I think is an important point to make. And Dr. Tegnell, what?
I mean, to me, like my Norwegian colleague said, I mean, this is public health. I mean, you don't have to start talking about economy because then you go maybe a bit too wrong, but we also know that the economy is very much connected to public health. So ignoring them completely, of course, does not make any sense, even if there are situations where you need to take quick decisions and so on. But I think that one of the problems we had at this time was that we focused so much on mortality, basically all through the pandemic, and saw that as the major outcome, which is, of course, it's not, because in the long term, a lot of other things are much more important for public health than the immediate mortality rates. So I think that was a problem and something that media sort of really played up, not least in Sweden, where we had a fairly high mortality in the first wave, but that we very quickly then saw that it sank and many other things went the right way. I agree with you about the schools, and we didn't really try to do it like that in Sweden. We tried to tell people that it's possible to run a school safely, and we could follow the morbidity and mortality among both the teachers and the children and show everybody there is no problem. I mean, teachers have any higher risk of ending up in hospitals than anybody else. And kids, at least in the first wave, hardly got sick at all. So I think if you had looked more at the data, I think you could have kept the schools a lot more open than you did in many places.
Yeah, and I think being able to analyze that data and look across, at Sweden compared to, things that were done here is a strong and important comparison to make. So, with the underlying public health policy is an implicit theory about which populations should be prioritized in a crisis. For example, the most vulnerable, the poor, the elderly, the young, the healthy, the middle class, the middle-aged. Which group does health, or which groups does health or public health prioritize? How large a role should the public play in such decisions vis-a-vis scientists or public health officials? One-size-fits-all policies is something that drove me bonkers. And a lot of the people that I've spoken with just could not understand the one-size-fits-all approach because this thing did affect different populations in different ways, whether it be within the United States, state by state, different countries, underdeveloped countries, things like that. So how large a role should the public play in such decisions? And I think I'll just start with you, Dr. Gandhi, and then we'll go around and see if what each person thinks again.
Well, I keep on going back to HIV because I think it's what I do nonstop. But there was a very big community-based response in HIV. It was always the community. I was just at a cure meeting in New York on Monday, and the community was just as important as the scientists when we were discussing particular strategies for HIV cure. So the community should have been more involved. We shouldn't have had one or two public health officials driving our entire response in something this big. It should have been child development specialists and psychologists and mental health professionals and those who care for the elderly and think about solitude and loneliness as part of a big panel and then making a very holistic decision. So we do need community-based and multidisciplinary responses in any pandemic, and that has actually worked really well for HIV, and I would encourage that for the next pandemic. The second is that we do have to protect those most at risk, because that's always been a public health principle. So with the John Snow, the pump in the cholera epidemic, you protect that neighborhood. You take away the pump in that neighborhood. You have to give people water, but you take away that pump because it was full of cholera. You weren't actually, the people who were wealthy reminded me of Uber Eats during the pandemic, but they were all getting food delivered to them with carriages from the poor people in London. So we do have to protect those most at risk, and that was a particular area in London that was most at risk for cholera because of the water pumps. So in this case, those who had comorbidities, those who were older, 65 and older, but certainly 80 and older, were most at risk, and those with immunocompromise. So we had to do everything in our power to protect them, including in nursing homes with both visitation, so protecting them from solitude, but also protecting them from infection. And so this one-size-fit-all didn't work because in this particular epidemic, children were much less at risk, but we closed schools. Maybe the next epidemic, children will be more at risk, and we'll close schools, and we'll let the elderly run free. Like, I don't know, but it has to be based on whatever this pandemic is, who it affects most. That's how we do our best to protect.
Back to the evidence-based
Yeah,
decision-making,
yeah.
right? Dr. Haug?
Yeah, I agree. And also, obviously, it's better when community is involved. But that also it means that the community must have information. And that's something we haven't talked about here. We may be talking about it more in later panels, but sort of the preparedness for what we do before the next pandemic. That people understand what an infection is, what immunity is, how people, how things will, some things that are uncertain, but other things are quite certain.
Yes.
We know that a new virus, a new or a sufficiently changed virus will make many people sick, and many people very sick at the beginning, and it will change over time. We know that. So that's, and the public needs to know that so that they're not scared more than they have to be.
That's important.
Because that, in this pandemic, I think with AIDS, it was also very scary in the beginning. I remember the sort of the Times magazine front page with exponential growth, we'll all die. But it's never exponential growth for a long time. You know, it's as Doug Owens said, you know, of course, in the beginning, it was very fast, but then for mathematical and logical reasons, it will flatten out. We know that, and we need to educate the population ahead of the next pandemic.
Immunity works, yeah.
Yeah, so that they can take part in these discussions. It's very difficult when you set the situation of this is so difficult, and this is only for specialists, and people felt that they just, at least in Norway, my country, different from Sweden, they were very afraid, and they were just like, we have to listen to the experts, and they did not want to take part in the decisions.
Right. Dr. Makary, something that you said earlier, and I know you talk about in your book, is, and you and Dr. Noymer had mentioned it here on stage already, was the comorbidities, and how much more prevalent comorbidities are in the United States compared to some other countries. And then when we deal with things, you know, and this is just to piggyback off this original question. If we apply the same policies here in the United States, when we know that there's a much increased factor of problems with people with more comorbidities, you know, prioritizing and that should take precedence over, you know, doing things in underdeveloped countries where they aren't dealing with these same kind of things. So touch on that a little bit for me, and then we'll kind of play on that down the line.
Nobody would talk about obesity or metabolic syndrome, the #1 most common modifiable risk factor of COVID mortality. No one would talk about it. No public health official ever would talk about it. And yet, in medicine, we have this culture of kind of blaming people for their diseases. Oh, they're disobedient. These kids have eaten too much. We told them not to eat too much. No, we're running the largest uncontrolled clinical trial in world history. We have poisoned the food supply with ultra-processed foods and thousands of chemicals in the American food supply that are banned in Europe and Canada. And then we've added toxins and chemicals and pesticides, and we wonder why we have half of our nation's children overweight or obese, and metabolic syndrome is surging. And so during COVID, you saw the similar dismissal, the similar, I would say, groupthink. We have good people in medicine, but they're working in a bad system. Doctors are great people, but we've done a terrible thing to doctors in this country. We've told them, put your head down and focus on what we tell you to do. And right now in medicine, we're making the same mistake. We tell doctors, put your head down, focus on billing and coding and seeing patients in short visits. You've got your prescription pad, you've got your surgical knife. Those are the only tools you can do. And we have not given doctors the time or resources to deal with the root causes of all of these diseases. And we saw that during COVID. And I think the biggest mistake was the failure to recognize the data early on, the 10,000-fold difference in risk between an older American with a comorbidity and a young, healthy child. We still see that sort of approach that we saw during HIV, that everybody's at equal risk. That was the sort of the motto. Everybody is, no one is, free from the risk of HIV. And look, I get it. Maybe during HIV that was the message. But you saw that transfer, everybody is almost, at risk of COVID. Well, we failed to recognize that a child was more likely to die of a firearm or drowning or an accident than from COVID if they were healthy. And the focus could have been on children with a comorbidity. Right. And then the last point, this is the last thing I'll say, is shutting down civil discourse. That was the biggest mistake. The most dangerous thing a government can do is fire the 2 top vaccine experts at the FDA, ream through the COVID booster approval under emergency use authorization for young, healthy kids, mandate it as a government, and then silence the doctors who question it. That is the most dangerous thing you can do. Now, it turns out the net harm to benefit ratio was relatively small, still a net harm, but that is a process that is a very scary process that we just witnessed in the United States.
Very dangerous path to go down. Dr. Noymer, your thoughts on that and prioritizing certain groups?
I recently had the pleasure to spend some time in Imperial County in California on the Arizona border. Where in the first 2 years of the pandemic, 0.5% of the total population of the county died of COVID. In the context of the United States of America, at least, protecting vulnerable groups was an abject failure.
Yeah.
In the U.S. or other countries as well?
Yeah.
I'm most familiar with the U.S.
Dr. Owens, your thoughts on that?
Well, I mean, the comorbidity question is one of a larger set of things that I think the point I'd make here is that we want to learn as much as we can about interventions from our colleagues in other places in Norway and Sweden and other parts of the U.S. But an intervention that works in one location may not work in another. It may be comorbidities, it may be cultural issues, it may be the way people live and multi-generational housing. Santa Clara County, believe it or not, is one of the most economically diverse counties in the country. You would realize that sitting right here, of course. But even within the county, there may be, situations where it's so different that an intervention that might be, work reasonably well in one part might not in another. So comorbidities is one, but I think these interventions have to be thought about and evaluated in the local context.
Yeah, I agree. Dr. Salomon, your thoughts?
I'll add a couple of brief thoughts. I mean, one is, you've heard a lot of cordial discussion, so I'll take an opportunity to gently disagree with something that Dr. Makary said, which is that I didn't hear any credible public health professional ever make a claim that risk was equal across ages. I think there are reasonable discussions about whether the interventions and priorities were appropriately titrated to that risk. And I think you could look at vaccines and say that they were rolled out recognizing age-related risks, other interventions less so. But I simply never heard anybody make the claim that risks were equal across the population. Let me add also that I think our evolving understanding indicated that once you go beyond a focus on mortality, there's a more nuanced understanding about risks in relation to age. I think the emerging understanding of long COVID indicates that a lot of people are vulnerable to that, including people who are young. So it may well have a less steep age gradient than mortality does. The final thing I'll say, because it hasn't really been focused on in this pandemic, is that besides the priorities relating to age, I think we all know very well that the pandemic exposed deep inequities in the healthcare system. And so we can talk about age, but I think we should not neglect to mention the disproportionate impact felt by historically disadvantaged groups. And so regarding the inclusion of public voices, absolutely public policy needs to reflect public values. I also think we need to acknowledge that we have imperfect ways of eliciting and understanding public values and incorporating them in our decision making. And one of the deep flaws is that when we try to do that, inevitably some of the voices that are always ignored are likely to be inadequately reflected. So it's a really important thing to aspire to do, to engage with communities, to reflect public values and public decision making it's hard to do. So I think we should commit to doing the hard work and getting better at it.
I think you make an incredible point. There's way too many people in this country whose voices aren't heard. They're often talked about but seldom spoken with, and that's one of the big challenges that we face in this country is getting those people to the podium, getting their voices heard, and I'll just point of privilege. That's one of the things that Braver Angels as an organization does very well is get people that don't often get the chance to speak, to get out there and get their voices heard. So that's just one of the things that I wanted to bring up. Dr. Tegnell, I want you to answer the kind of give your thoughts on the prioritization of getting the voices of the people heard, and then I do have another question directed for you that I would like to run by you.
No, but I completely agree. I mean, priorities are important in a pandemic. And I think the ethical platform in Sweden is also very clear on that the persons who are at the most need should also be the ones that gets the first, and we worked very much like that with the vaccine, for example. Then sometimes it becomes difficult because, I mean, with the elderly it was quite clear. And in Sweden, comorbidities did not play out that much. It was really age that was the big risk factor. So that was a group that, but then we found out that we had other groups in Sweden that we sort of knew about but had not really addressed very much. I mean, many of our migrants or newcomers from other countries were also hit very, very badly because we didn't really reach them. And we were not really able to protect them in the way we should have. So this was a big problem and something we really need to address before the next pandemic, because it's not the kind of thing you fix during a crisis.
No, absolutely, that's very important. So Dr. Tegnell, please give some examples about interventions that were easy to start and hard to stop. That's one of the things that you brought up earlier, and I think I'd like to unpack that a little bit. What's a good decision-making process for implementing policy that takes this insight into account, that policies are easy to start and hard to finish?
I think this comes back to the precautionary principle that was talked about a lot about Sweden. You should really sort of do everything, start with everything, and then maybe start slowing down. And I think that comes from the emergency medicine. I mean, if you have a big train crash, this makes sort of sense to send all the people there and then take some of them back. But it does not really make as much sense during a pandemic because that's going to take a long, long time. So you need to start thinking about measures already early on that's going to be possible to keep. And locking people inside is not going to be possible to keep. But trying to have a kind of intelligent discussion with your population about how can we keep a distance, how can we stop meeting as many people as we usually meet, that you can do. And I think you need to be very clear about telling the people what you're trying to achieve, not exactly how to achieve it, because everybody is different. Mm-hmm. And some people need to go to work and all of these kind of things, but they can still diminish their contact with other people with maybe cycling to work instead of taking the subway and stuff like that. So I think we managed to do that to a certain extent, to get people to understand what do we need to achieve. We need to achieve fewer contacts. And each person can sort of take that home and see, what can I do?
Right.
Do this. I think that's very much what it comes down to. And then you don't really run into the problem about starting and stopping things. Because if you have sort of tell them, this is the goal, this is where we want, this is the change in your behavior that we want to have.
Right. A lot of it comes down to the communication and the transparency, right?
Exactly, and having a kind of intelligent conversation with your population to understand their needs compared to your needs to sort of slow down the spread.
Okay. So I'm going to start down at that end and then work back this way with this question. According to the WHO, we are still in the SARS-2 pandemic. The toll of long COVID is so enormous, or is enormous. What should governments be doing to control the current pandemic? Start down at your end, Dr. Tegnell, if you're going to...
I think we need to recognize that COVID is with us to stay.
Yeah.
That's a discussion we had early on, and it's not like the SARS and MERS, which we managed to get rid of, but we must understand that that's the exception. Most of the time, we're not going to be able to get rid of disease. This is not as easy as we think. Smallpox, to a certain extent, was a problem in that way because we managed that, and then we think we can do it with so many others, but it's very much more difficult than that. So we need to establish a strategy over time that can work. And I think, at least in Sweden, COVID at this stage is this kind of seasonal disease that we need to vaccinate the risk populations for. This is what we're going to have to go on doing for a long time. If we call it pandemic or not, it doesn't really make any difference.
Okay. Dr. Salomon?
Yeah, I agree with that. I think some of the things that have come up in the conversation are really important. I think we need to invest in surveillance systems so that we really can understand risks as they wax and wane. I think there's been a lot of progress in novel surveillance methods like wastewater that everybody hears about. But I think our ability to manage a infectious disease, whether it is in a pandemic, in an emergency, or an ongoing threat that still continues to cause risk and harm to people, I think we really need to be able to understand and measure well the current status. And for the reasons that Dr. Tegnell was talking about, I think public health officials need to be equipped to be able to describe the situation in ways that are honest and reflect the uncertainty, to describe pandemic or public health policies in relation to that situation, including things that he was talking about, like decision rules for changes in policies in relation to the situation. All that depends on having the best situational awareness that we can.
Okay. Dr. Owens, your thoughts?
Well, I agree with that completely. You mentioned long COVID. I would just say something about we want to, of course, prevent new infections, but we have millions of people who are suffering now, and we have, not much to offer them. I think that's an area where we need to invest, certainly, in research and understanding what the best care models are for those folks. How do you do patient-centered care? So we want to both try to prevent the new infections, and we want to, I think we've maybe lost our focus a bit on trying to help the people who have, tremendous morbidity already and what we can do about them.
Thank you. Dr. Noymer.
In the 19th century, the great public health innovation was John Snow discovering by studying water suppliers and cholera risk in Victorian London that infectious disease is spread by germs. And the response to his work was to invest billions and billions in sewage systems that keep wastewater and drinking water in separate channels. The great public health crisis of the 21st century is COVID, and what we need to do that will be the comparable intervention to building sewage systems is to improve the quality of indoor air through filtration, ventilation, outdoor air exchange, and in some cases, treatment with ultraviolet light. And the White House Office of Science and Technology Policy spearheaded an intervention to do all of these things. It's been very quietly but thoroughly shuttered, as far as I can tell. Alondra Nelson is back at the Institute for Advanced Study. There's a new White House science director. They seem to be doing absolutely nothing along these lines, and we've missed a tremendous opportunity to start tackling the problem, and it mystifies me.
Yes. Dr. Makary, I know we're getting close to the end of our time here, and I want to leave about 30 seconds for everybody to toss out some closing remarks. So if you want to go ahead and...
Be quick, okay. A couple things for the record. I never said public health officials said everyone was at equal risk. They said everyone is at risk. And when you say that over and over again, and you ignore other risks in people's lives, you create this intense fear. And it's not the first time we've seen it. Yes. Also, Sweden and Michigan have the exact same population and the exact same proportion of people over age 65. The obesity rate of the United States is 27% among adults. It's 12%. They like candy bars too in Sweden. And so that difference does not explain the radically different outcomes. And so we've got to look at data. We can't just be like, oh, there's other issues involved, let's blow it. This is the largest public health intervention in human history. We have got to evaluate how we did. And we did terribly on putting cloth masks on kids for 3 years as young as 2 years of age. Cloth masks didn't help. We closed schools and shut kids out for a year and 9 months. It's not like they made a quick decision based on the information at hand. No, this persisted, and many of us were trying to sound the alarm and talking till we're blue in the face. And what did we end up with? Tremendous lifelong learning loss, a 12-point IQ drop in the Brown University study that just came out. And you know what? Closing the schools is fine if you're wealthy, like everybody in this room. But come to East Baltimore and watch a kid where the school already has a 40% retention rate and see how they do with getting an iPad and going at home and living in their home in lockdown. So the untold story of the pandemic was its disproportional effect on poor and minority communities. You've got to apologize when you make mistakes. That's why public trust is down. Medical field thinks public trust is down because some people were saying there's a microchip in the vaccine. No, public health trust is down because people realize they were lied to for 3 years.
Good point. That's a good point. Dr. Haug and Dr. Gandhi, if you could give your closing remarks, and then we'll give everybody else about 30 seconds to. So, Dr. Haug.
Yeah, I'd like to bring up something else that this pandemic exposed, and that's how we organize our healthcare systems, how we treat our elderly. Because one of the reasons that we had these very scary pictures from Italy that motivated the lockdowns was actually that Italy had closed down a lot of its public hospitals, has very little capacity to receive new patients. The intensive care units were already full, so if you have 2 extra patients, it looks like a crisis. So we have to think about that. This didn't happen in most Asian countries. In Europe, we had a difference between our country and, for example, Germany, who has more flexibility in the intensive care units. There will be sick people during a pandemic. We need to look at that. If we want to have our elderly in nursing homes, I had my father in a nursing home at the time, we maybe have to invest more in people having full-time jobs when they work there to take care of them. These things we also have to prepare for the next pandemic.
Yes, absolutely. Dr. Gandhi?
My final statement would be on poverty. I'm very interested in global disparities in poverty, and I think a lot of people who are talking, like myself, about school openings and a more holistic view of society was very worried that there'd be a deepening of poverty, and especially of multidimensional poverty for children, and that's exactly what happened. So I think we haven't mentioned directly that the school closures, though Marty mentioned it, affected Black and brown impoverished children more than the people who could afford to send their children to private schools. So I think anything that we talk about with health, we have to include the impact, the terrible impact of our disparities in poverty.
That's absolutely right. That's absolutely right. All right, I'm going to start with you, Dr. Tegnell, and then work this way for just a quick 30-second wrap-up, final thoughts, and final words for our audience.
Yeah, I think one of them is how important data is going to be in the next pandemic, and we need to be a lot more flexible about looking at different kinds of data, not just the traditional ones. And then coming back to equity. We need equity and trust. This is what we need to build before the next pandemic. I think that's a lot more important than buying more respirators or whatever.
Absolutely. Dr. Salomon?
Yeah, let me just end by thanking you once again and thanking all of you in the audience for participating. I think there's a theme that you heard from virtually everybody who's spoken today, which is trust and the primary importance of rebuilding trust. And so I'd say the things that we really need to emphasize is transparency and adaptability among decision makers, including public health decision makers, and agree with Dr. Tegnell. We need to empower them to be transparent and adaptable with good data systems and the supports that they need.
Very good. Dr. Owens?
Well, first, I just want to thank you, Wilk, for a fantastic job moderating. I don't have much more to add beyond what they've just said. I think that, the old saying is you don't wait till you have a fire to build a fire department, right? We have to invest in public health in between these crises. The pattern usually is public health gets money when there's some disaster going on, and everybody forgets about it. We're going to have the same problems. We don't have the data systems. We don't have the surveillance systems. We don't really have adequate early warning systems. There are early warning systems for missile defense and things like that, but we need those kind of things. So this is the time for us to make those investments. I'm not sure how to get people focused on it, but we have an opportunity to do better if we can improve, our data and our trust.
Very good. All right, I would like to just thank everybody on this panel today. We heard a lot of different perspectives. We're out of our time for today, but thank you so much for modeling just an absolutely beautiful conversation. A lot of different viewpoints, just a true display of professionalism and a beautiful job. Thank you so much. Thank you to the audience. I wish I could have got to more of your questions. And, I appreciate you.